This year has been astonishing at the fact that we're having multiple combinations. So this is a new era where we have established very active therapies, specifically the JAK inhibitors for polycythemia vera and myelofibrosis. And now we're trying to build on that success. So we're trying to add additional agents that would either give you a deeper response or a more durable response or additional clinical benefit. So these are some of the most exciting agents. There are multiple examples of combinations that we can go over, but there's plenty of exciting data in ASH 2019. Well, it's a wonderful tool to have for our patients. So we are starting to design smart clinical trials that are directed to patients with individual mutations, like IDH mutations. So there's now clinical trials designed to include specific patients with certain mutations on specific therapies. We're also starting to correlate how patients' clinical response is explained by their genetic makeup. And some patients with particular mutations are more likely to respond to certain therapies or be unresponsive to specific therapies. So this is becoming a standard of care for all patients at diagnosis and at every cancer event that they have, both for response assessment, for likelihood of response, for prognosis, and also for choice of therapy. We're also able to refine prognostic models based on mutations. So for patients who are considering bone marrow transplantation as a curative therapy, I think the molecular mutations have been a very important tool in risk stratifying patients on who should be referred to a transplant sooner based on their clinical features. Absolutely beautiful question at this time and era, because we are trying to create certain response criteria and definition. So patients who respond have specific needs other than patients who fail early or fail late or respond suboptimally. So we're starting to design clinical trials specifically based on patients' clinical behavior and the response to therapy. So, and this is a great time for this because we have multiple treatment options that have specific benefit at specific clinical vignettes. For example, patients who fail ruxolitinib early are likely to respond to other JAK inhibitors that do not include ruxolitinib. And patients who respond to ruxolitinib might benefit from add-on or add-back strategies with combinations. And patients who fail JAK inhibitors completely are candidates for novel agents that can affect the cancer stem cells or have more disease-modifying agents at possibly higher toxicity. But those patients would likely to benefit from a non-JAK inhibitor combination. So the response to therapy has been absolutely a useful tool in deciding which second-line therapy you would gear your patients towards. For primary myelofibrosis or secondary myelofibrosis, ruxolitinib has been the first-line therapy with excellent results and high rates of responses that are durable. But the eventuality of this is that most patients will progress either completely or partially while on therapy of ruxolitinib. And the symptomatic progression or clinical progression is something we need to plan to. And for that, we're fortunate to have a second JAK inhibitor that is approved this year for many patients, which would be a good option for patients who are not successfully treated with ruxolitinib. The pattern of progression and the pattern of loss of response, the timing of loss of response, can be very helpful for physicians to navigate through the clinical trials that are available right now and to which when should we gear patients. So patients who continue to have some clinical benefit from ruxolitinib might benefit from an add-on or an add-back strategy where you utilize combinations to improve their progression. And now we are also in an era where there are multiple disease-modifying agents that work as a single agent or in combination in that setting. So that could be also an option for those patients. For polycythemia vera, hydroxyurea has been the first-line therapy. Interferons have also been studied in first line and in second line. The body of evidence is growing. Every ASH meeting and every scientific meeting, we're having more interferon updates, both in first line setting and in second line setting. And it is a very good option for most patients with polycythemia vera who do not have contraindications for interferon. The activity is solid and durable and also reaches to molecular responses. So this remains a very good option for patients in second line setting. There has been the approval of ruxolitinib in second line after hydroxyurea failure, which is also has been updated with a 4 to 5 year responses that are durable, and it's a very good option for our patients. More recently, there are some novel agents that are being developed, including MDM2 inhibitors, although the development of these drugs are at a standstill at this point. And there are a few promising molecules that are hepcidin agonists that are coming to the clinical trial portfolio and would be a very powerful tool for our patients with symptomatic progression. Well, there is a complete oral session today with six oral presentations about combination this year. It's a very exciting time where we understand the activity of ruxolitinib in myelofibrosis, and now we're starting to build on that. So among some of the novel and smart combinations is the combination of ruxolitinib or JAK inhibitors with BCLX inhibitors. This is still early, and we're looking for more details and more information, follow-up on patients. Also, the combination with bromodomain inhibitors, which is something we're all excited to hear about, especially with the anemia responses. One of the most exciting and scientifically intelligent combination is the combination of JAK2 inhibitors with PI3K delta inhibitors. Blocking the two pathways resulted in significant responses and very little toxicity. There's no updates in this ASH meeting, but hopefully we'll hear more about this in future meetings. But this is a very exciting and likely a very powerful way in treating myelofibrosis. So for polycythemia vera, we're looking forward at combinations in second line setting with active agents, whether it's interferons or ruxolitinib or hydroxyurea, along with the hepcidin agonists, which would result in avoiding the need for therapeutic phlebotomy in those patients. So this is an ongoing endeavor, and we're going to hear about it hopefully soon.